Hi, everyone. Sorry for the technical difficulties on my part. Today, we're going to have Dr. Matthew Lokant. He's an infectious diseases physician currently serving as the system healthcare epidemiologist for the West Virginia University Health System, or WVU Medicine System. He's originally from Oak Hill, West Virginia, and he completed undergrad, medical school, and internal medicine residency at WVU. He then completed an infectious diseases fellowship at Vanderbilt University Medical Center as a chief fellow in 2024. And he also completed the LEAP fellowship for leaders in epidemiology, antimicrobial stewardship, and public health fellowship, sponsored by IDSA, SHE, PIDS, and CDC for the 23-24 academic year at the Tennessee Department of Health. His professional interests include medical education, hospital epidemiology and infection prevention, and antimicrobial stewardship, with further collaboration in research, public health, and global health. And he hopes to become a leader in healthcare epidemiology while championing high quality patient care and medical education. Um, and I will pass things over to Dr. Lokant in just a couple minutes after I go through our introduction slides for the Mid-Atlantic AIDS Education and Training Center here. I work for the West Virginia local partner site of the Mid-Atlantic AIDS Education and Training Center. And we help plan these ECHO sessions with Kelly and Chantry. So this project, the MATEC project, is supported by HRSA and US DHHS as part of a grant, and the contents of the presentation are those of the author and do not necessarily reflect the views of HRSA, HHS, or the US government. Next slide, please. And our mission is to improve the quality of HIV care outcomes for people with HIV and communities disproportionately impacted by HIV across the US and its territories. And we want to transform HIV care by strengthening systems of education, consultation, and support, and advance a unified interdisciplinary workforce equipped to meet the evolving needs of patients and clinicians nationwide. And then this is just Dr. Lokant's information, and I already read his intro, so I'll go ahead and pass it over to you, Dr. Lokant. Thank you so much for presenting for us today.
Yeah, thanks so much for having me today. I'm really excited to provide some updates here. So the objectives today, we're going to differentiate high risk versus low risk occupational and non-occupational exposures for HIV based on fluid, route, and source characteristics. We'll talk a little bit more about that here in a minute. And then the rest of these objectives are sort of interwoven to make sense on what we really need to think about with a post-exposure prophylaxis. So interpreting those baselines and follow-up labs for HIV, and then I've incorporated some with hepatitis B and hepatitis C algorithms. Evaluating our patient as well as exposure-specific factors, evaluating the risks and benefits for post-exposure prophylaxis, designing appropriate follow-up schedules for testing as well as clinical monitoring. And then last but not least, what we really should be doing throughout this is developing patient-centered education plans, really addressing behavioral precautions as well as psychosocial concerns, because we need to make sure we're taking care of our patients and our communities. So let me start with our 4 practice-changing updates for 2025. I'm going to interweave these throughout the presentation, but these are the biggest changes that were updated within the CDC guidance. So first, immediate initiation. We're moving firmly towards same visit post-exposure prophylaxis start. So if an exposure is credible, do not delay for lab results. Every hour really matters with viral replication kinetics. Our job is to assess risk quickly, so the fluid, route, and source, and then start treatment. Secondly, here, there's a new preferred 3-drug regimen guidance. So utilizing things from the past as well as other newer strategies. So guidance continues to favor our integrase inhibitor-based triple therapies for tolerability, potency, as well as the resistance barriers. So think rapid start, minimal drug-drug interactions, and regimens patients can actually complete for a 28-day course. Thirdly, nucleic acid testing or NAT for long-acting PrEP. This is critical because before starting or continuing long-acting PrEP or post-exposure prophylaxis, we need HIV RNA testing, not just antibody antigen assays. So to avoid initiating injectable therapies during acute infection and driving resistance. We'll talk more about the nuances here later. And then fourth, immediately transitioning to PrEP or pre-exposure prophylaxis. So if someone is completing PEP, we should not have gaps in prevention. So if a patient has ongoing risk factors, bridging from our post-exposure prophylaxis to pre-exposure prophylaxis without interruption. This is a systems issue as much as a clinical one. So setting up follow-up before a patient leaves, all of these nuances we need to be thinking about. So getting back into this, when assessing a healthcare blood exposure, there can be many initial thoughts that go through our heads, but what really should we be doing? So first of all, soap and water. They're key to reducing any infectious burden that may have been present on initiation. So washing needle sticks, cuts, exposed areas with soap and water is priority here. Concurrently, consider splashes to the nose, mouth, skin with water. If it's a mucous membrane exposure, flush it with water or saline. And then ultimately, we need to be concurrently reporting these incidents. So to your supervisor, a designated person in your facility to really streamline this process. Organizations have persons directly trained in this area, so employee health or infection prevention that can help guide what can be scary and concerning for an infected individual. We want to seek immediate medical evaluation, so documenting that exposure, providing details on the incidents, including the type of exposure, the source patient, if known, and the circumstances of the exposure. We'll talk a little bit more about baseline testing here in a minute, and then concerning the source patient thereafter. So let's ground ourselves in what actually constitutes a meaningful HIV exposure, because most anxiety we manage clinically comes from those events that are not truly high risk. So start with the fluid. Only a short list of fluids carry a substantial risk, those being blood, semen or pre-ejaculate, vaginal amniotic fluid, or breast milk. Next, consider that route of exposure. So it's risk driven by how the fluid enters the body. So percutaneous injuries, needle sticks, or deep dish tissue injuries carry those highest risk for an occupational risk. Mucous membrane exposures, such as the eye, mouth, rectal, vaginal, are lower risk, but still can be clinically significant. And then non-intact skin, so think dermatitis, abrasions, open wounds. These can also matter, but again, the risk is generally lower than our percutaneous exposures. And there's an important distinction here. So there's other body fluids, so feces, saliva, sweat, tears, and urine that are not considered infectious unless visibly contaminated with blood. That distinction really alone prevents a lot of unnecessary post-exposure prophylaxis starts. A true exposure requires multiple elements, the right fluid, the right route, and a plausible source. So if one of those is missing, the risk drops really dramatically. This framework really ties directly into our first objective, distinguishing that high versus that low risk exposure so that we can make a rational and a timely post-exposure prophylaxis decision and avoid both under treatment as well as over treatment. As we discussed earlier, there are many areas we should be aware of, including those percutaneous mucous membranes and cutaneous with non-intact skin exposures. Before any of these things happen, we need to try to embed safeguards in our practices to really reduce that chance of these events occurring. So, for example, in a hospital setting, needle stick injuries are usually a large concern, and in limiting unnecessary use of needles, not recapping needles, and proper disposal are all tactics to avoid these injuries in the first place. That is why it's so important for us to maintain compliance with these elements and promote education and a safe work environment. As a hospital epidemiologist, I can't resist not incorporating some numerical data. So humor me for a minute. When looking at how the risk of acquiring HIV of an exposure, I want to provide some of the numbers to demonstrate that magnitude. So for those with a percutaneous injury, such as a needle stick, HIV transmission occurs in about 1 out of 435 episodes. Factors that increase that risk include things such as a hollow bore needle, a visibly bloody device, deep injury, or a device in an artery or vein. Mucous membrane exposure, eye, mouth, genital, rectal, drops off substantially. So risk is about 1 in every 1,000 episodes. And here the volume really matters. So a small splash is not going to be the same as something that has like a large inoculum. For cutaneous, specifically that non-intact skin exposure, risk is less than mucous membrane exposure. Intact skin is an excellent barrier, but when that skin gets compromised, so think dermatitis, abrasions, open wounds, then we can really consider that a risk, but it remains very low overall too. Outside the scope of this talk, there are other forms of HIV acquisitions. We're going to go through them though, too, with like sexual exposure, human bites with blood, breast milk, and blood transfusion. I dedicated this talk more so for post-exposure prophylaxis in an occupational setting because that's what I deal with on the day-to-day. And then this is just for reference. I wanted to provide some information on the odds of acquisition regarding these types of exposure as well. As you can see, blood transfusion with a donor living with HIV has the highest percentage. It makes sense. I updated this data from obtained this data from the Johns Hopkins clinical pathway guidance. So you can use this as a reference to really show the magnitude of difference. And it really matters of being able to look between our high as well as lower risk entities. So from this information stems our desire to really prevent HIV. The original study for post-exposure prophylaxis, or PEP, is from the 1997 Cardo and group study, where they used zidovudine, and it was implemented as PEP for healthcare workers, reducing the risk of HIV acquisition by 81% overall for percutaneous exposures. So really effective right from the get-go. In actuality, PEP blocks viral replication and prevents an exposed individual when initiated within 2 hours, ideal, and no later than 72 hours after an exposure. So most importantly, rapid and effective response here to a reported HIV exposure is the key to be successful in prevention HIV infection. When looking into the timeline of what should ideally happen with PEP, we start with the baseline testing. So this includes HIV antigen as well as an antibody. HIV antibody rapid HIV testing is preferred if accessible. And HIV is not unique with an exposure. There are concurrent concerns. So here are a list of other labs to consider when you're doing that initial exposure workup. And once again, you're going to be talking with the person exposed to sort of give a full picture of how you should be tailoring your objective workup. So big update here is if a patient has been on long injectable pre-exposure prophylaxis, so think something like cabotegravir, in the past 6 months, diagnostic HIV nucleic acid test is now explicitly recommended in addition to antigen antibody. And that's because we might have a delayed positivity of those prior labs. So this is another way for us to make sure that we're honing in on this and making sure we're not missing other people. So remember that time window, ideally with 2 hours and a max of 72 hours for PEP initiation with a first dose of that medication ASAP. The status of the source patient is important, but should not impede treatment if this is unknown at the initial concern. So we should not really be waiting for source testing unless it's readily known. This brings us to that 2025 update, specifically with the 72-hour window. We want to make sure that we're trying to do this as early as possible. There's a rapid decline in the post-exposure prophylaxis efficacy over time, and our goal is to really stay firmly in that green zone. So optimal initiation is immediate. So ideally within those first hours, not days. So by 24 hours, we're already seeing declining theoretical efficacy. And after 72 hours, we're at that outer limit. So post-exposure prophylaxis is generally not recommended after 72 hours. HIV establishes a local infection quickly and begins systemic dissemination within days. So post-exposure prophylaxis works by interrupting that viral replication before permanent infection is established. Once that integration occurs, we lose that window of opportunity. So from a clinical aspect of how I frame this, 0 to 24 hours, treat this as an emergency. It's start post-exposure prophylaxis now. 24 to 72 hours, still offer post-exposure prophylaxis, but that benefit is likely remaining, but so we don't want to withhold. Over 72 hours, in most cases, we don't initiate post-exposure prophylaxis. The shift goes to testing, counseling, prevention planning. So post-exposure prophylaxis is generally recommended when the source of patient has HIV. Generally not warranted when unknown, but this should be on a case-by-case basis. And if there is a concern for HIV, then that will be where you would do post-exposure prophylaxis. If a source person is in the window period, so where a lab may not reflect true status, then an HIV viral load should be entertained as something that we consider. That being said, we don't want to delay post-exposure prophylaxis initiation, and this should be started. So of note, as of current date, there have been no documented cases of occupational transmission during the window period in the United States. We do use post-exposure prophylaxis, but we're no longer using zidovudine. We use a 3-drug regimen. If considering a 2-drug regimen, it's not generally recommended. This should be with expert guidance. The drugs historically recommended prior to the 2025 update were tenofovir, emtricitabine with either raltegravir or dolutegravir. Newer data had suggested that tenofovir, alafenamide, emtricitabine, and bictegravir, given that it's a popular, well-tolerated regimen. That being said, most data is after sexual exposure and not as well documented in the occupational exposure literature. So our next deep dive into the 2025 updates, looking at the regimens. So we have 2 preferred integrase inhibitor-based options, and selection should be individualized based on the patient and exposure factors. So option 1, so TAF or tenofovir alafenamide, emtricitabine, FTC, or bictegravir, BSE. Think of this as a single tablet regimen option in practice. It has excellent tolerability and a high barrier for resistance. So great option here for post-exposure prophylaxis. Another option, very similar to what we had historically used prior to the 2025 update, tenofovir dysproxyl fumarate or TAF, emtricitabine or limivudine, and then dolutegravir. Not a key update here, but raltegravir is typically off the newer guidelines. It's typically no longer preferred because of the simplicity of a dolutegravir medication regimen, as well as how many times you have to take it in certain patient populations. So just more from a tolerability and feasibility, it isn't listed in the 2025, but it's not saying that this would be an inferior regimen to consider. So it gets back to consider your patient population as well as your exposure type. There are a few key nuances that aren't really specifically talked about, but you can see this within the literature. Tissue pharmacology really does matter. So AF achieves lower drug concentrations in vaginal tissue when you compare that to TDF. Why does this matter? If you're managing receptive vaginal exposures, particularly like a non-exposure occupational exposure, you might want to consider a TDF-based regimen because we do have stronger pharmacokinetic and clinical prevention data in vaginal tissue. Another key nuance to point out within the evidence gap, there's less clinical data for TAF in injection drug use associated exposures. So in scenarios like needle sharing, high risk percutaneous community exposures or something like that, many clinicians still lean towards a TDF-based regimen where the evidence is a little bit deeper there. So when starting PEP, you'll want to continue for 28 days. I'd like to point out to avoid starter packs if possible. You don't want any pauses in that prophylaxis. And then whenever you're starting a new medication of anything, you need to check for drug-drug interactions. And consider a few scenarios for extension. So indeterminate testing, acute retroviral syndrome concerns, and pregnancy with high probability of exposure. That being said, you want to ensure patients are tolerating these medications for both compliance and effectiveness throughout the duration. Typical side effects include GI and nonspecific symptoms. However, tenofovir DF might have some associated renal toxicities to monitor for. I mentioned acute retroviral syndrome, so I wanted to point out some of the symptoms here that can be associated with that, with an acute HIV. Predominantly, we think of this as an influenza or mono-like illness, but there are multiple manifestations. So just have it on your radar if you have somebody who's had a potential HIV exposure. You don't want to miss that as a non-specific illness at the time. I've highlighted some of the important key facts of the medications we talked about. So for emtricitabine, so overall, this is a well-tolerated backbone agent, and providers are typically pretty comfortable with it. A few key points to emphasize is you want to co-administer this with lamivudine. They're both therapeutically redundant if you were going to double up on that. What about Biktarvy for PEP? So yes, back to my I didn't call out the actual drug name, but that's what the first regimen that I pointed out. These are the components for Biktarvy. Uh, Predominantly, we think of influenza or mono-like illness, but multiple manifestations. Apologize. Going back to the emtricitabine, dose adjustments required with creatinine clearance less than 50. Side effects are minimal, but you see hyperpigmentation of the palms and soles. So think about this in a patient population while you're counseling, so it doesn't become an adherence issue in the long run. For bictegravir, so one of our preferred integrase inhibitors because of simplicity as well as tolerability, drug interactions, so think strong CYP3A as well as UGT1A1 inducers. So there could be some chelation interactions as well. So these are where you want to make sure that we're not missing any drug-drug interactions and then separating it from certain supplements. So antacids, iron, calcium. So giving 2 hours before, 6 hours after administration of those elements. And then renal considerations. So if somebody does have a creatinine clearance that's less than 30, you really want to typically avoid that. But I would do that on a case-by-case scenario with a discussion. Side effects, pretty much well tolerated, possible insomnia, GI issues like we talked about. And there is some data with a modest weight gain. Tenofovir alafenamide. This is where we individualize, so less renal and bone toxicities compared with TDF. So that's the major advantage here. You would want to watch for PGP inducers, which can reduce drug levels. So once again, looking at drug interactions. And then again, with an HBV flare, if this continued, you really want to think about that or emtricitabine in those cases. Dose adjustments are avoided needed at creatinine clearance thresholds depending on the formulation. So really want to make sure that you're being cognizant of their renal status at baseline. Once again, very well tolerated, sometimes associated with headache and nausea being the most common. So what are the key things here? I would ask you to think more longitudinally, not episodically. This isn't just about a one exposure. It's about future risk reduction, behavioral counseling, and addressing psychosocial concerns. So stigma, access to care, anxiety. With patients that have ongoing risk factors, really consider bridging directly to pre-exposure prophylaxis after completing PEP. So let's talk about population where hesitation can be common, but delay is where harm could happen. So pregnant and breastfeeding individuals, it's something that I get asked about a lot. So key point number one, do not delay PEP just because of pregnancy. If the exposure is credible, start post-exposure prophylaxis. The risk of untreated HIV acquisition far outweighs the potential medication risk based on our current safety data. Yes, we should counsel on the potential fetal exposure, but this needs to be evidence-based and reassuring. We now have extensive safety data for commonly used agents, so TDF, FTC, and dolutegravir have had strong safety profiles in pregnancy. No signal of increased major birth defects and current recommendation regimens. So conversations really should have these medications are considered safe, and preventing HIV acquisition is a priority not just for you, but for the developing fetus. Pregnant persons receiving antiretroviral therapy are encouraged to enroll in the antiretroviral pregnancy registry. I'll put the .com here website. This is important for ongoing pharmacovigilance and strengthening our future safety data. A critical point here is acute or newly acquired HIV during pregnancy is associated with significant higher risk of perinatal transmission, largely due to high maternal viral load and lack of established viral suppression. So when we delay or withhold post-exposure prophylaxis, we're not just risking the maternal infection, we increase downstream vertical transmission risks. Available data shows no increased risk of major birth defects with recommended antiretrovirals compared to the general population. Medication toxicities are not increased in pregnancy in a clinically meaningful way in the majority of cases, but be cognizant of that. And then available data are reassuring and do not show increased risk of birth defects or significant toxicities with recommended post-exposure prophylaxis regimens. So again, we still use standard 3-drug post-exposure prophylaxis regimens, and importantly, pregnancy does not change the need for effective, fully suppressive regimens. Overall, these regimens are well tolerated with low drug-drug interaction concerns. And even though raltegravir was not chosen in these most recent regimens, if it is chosen, you do need to think about the pharmacokinetics and dynamics where that would change to a BID dosing strategy or twice daily. Most recommended agents have low transfer into breast milk. So infant drug exposure is minimal and not associated typically with a clinical significant toxicity based on current available data. But once again, this is something that you will want to counsel your patients on and do a individualized discussion. So let's shift away from HIV for a second and talk about hepatitis B as well as hepatitis C. So because unlike HIV, we do have a highly effective immunization, at least for hepatitis B, which completely changes our post-exposure prophylaxis management. So first, if the source is hepatitis B surface antigen negative, you're not really at risk for hepatitis B there. You don't really need any post-exposure prophylaxis. If the source is unknown or unavailable, management should be based on the exposed person's vaccination as well as immune status. So if the exposed individual has documented immunity, and that's typically when you have a surface antibody greater than 10 after vaccination, then you would consider this an immune person and no post-exposure prophylaxis is needed. It's a key teaching point here where immunity is durable. These individuals are protected even after an exposure. For a known responder after vaccination, once again, I wanted to put this in a tabular appearance. No testing is needed, so no post-exposure prophylaxis. If it's unknown response, then act based on the result. So if you have a surface antibody that's greater than 10, once again, no action needed. If it's less than 10, you would consider hepatitis B immunoglobulin if the source is positive or unknown, and then initiate or complete the vaccine series and check the anti-hepatitis B core prior to that infection. I'll just keep these notes within here, but there's good clinical guidance on this from the CDC. If your surface antibody is less than 10, once again, intervening with that immunoglobulin and vaccination based on the source. To get a little bit more into that, for a true non-responder, so say we'll have patients that have had multiple series of hepatitis B. This is a high-risk group. If they're not responding and not having an antibody, no further vaccination. They've already failed series before. So in these situations, you typically give the immunoglobulin, and those are typically 1 month apart. The teaching point here being individuals cannot reliably mount protective immunity, so we give that antibody to them. If someone's unvaccinated or incompletely vaccinated, we could still intervene here effectively. So they don't have any antibodies yet, so you will want to give that immediately. But then you could start or complete the hepatitis B vaccine series, and that timing really matters. So hepatitis B immunoglobulin, you typically want to give that within 24 hours. It can be given up to 7 days for a percutaneous exposure. Now, swapping from hepatitis B to revaccinated with standard. Sorry, I see a question. Revaccinated with standard dose or double dose. Um, Typically, that's at a individual institution's discretion. I would take it in coordination with the actual patient. So, say somebody's never been vaccinated, then typically you would just do a standard approach there, not a double dose. And now there's also newer formulations of hepatitis B vaccination. So I would see what your current facility has on access. Um, Next, for an exposure to hepatitis C, where the management paradigm is very different from both HIV and hepatitis B. So transmission risk is lower, but not zero. So a percutaneous exposure, you could think of that risk being about 0.2%. Mucocutaneous exposure, essentially 0%. From our available data, we really haven't had any transmission there. So compared to HIV and hepatitis B, the absolute risk is lower, but still can be clinically relevant, particularly with a sharp or needle stick injury. So no exposure prophylaxis is the major takeaway here. We don't have a recommended post-exposure prophylaxis regimen for hepatitis C. We do not give antivirals after an exposure. Instead, management is focused on early detection and then prompt treatment if infection does occur. So early infection is detectable quickly. So your HCV or hepatitis C virus RNA becomes detectable after about 1 to 2 weeks after an exposure. That antibody develops later and it can lag, so typically 8 to 11 weeks. So unlike our older paradigms, RNA testing is critical for early diagnosis here. So if the source person is hepatitis C positive, test the exposed person baseline. So you would take the antibody plus or minus RNA there and follow with serial hepatitis C RNA testing and refer the source person to care if not already linked. If the source hepatitis C negative and it's a true negative source, there's really not a transmission risk there. And so that can be, that concerns null. What we typically get into is with a source that's unknown. So there's some nuances here. So a preferred test here would be a hepatitis C RNA, and that would detect active infection ongoing. If that's negative, no follow-up's really needed because you haven't been spreading the hepatitis C. There was nothing to spread. From a positive, you would proceed with an exposed person test and follow up. So let's look a little bit more into that. So if you have an HCV that's unknown, you would initially test the source. If available, start with the antibody. And if the antibody is negative, no further testing needed, no infection, no transmission risk. If the antibody is positive, you would reflex to an HCV RNA. That's a critical step because the antibody just tells you exposure. The RNA is what's going to tell you an active infection. If that RNA is negative, there's no current infection, no transmission risk, so no follow-up for the exposed person. If the HCV RNA is positive, you do want to test that exposed person, baseline and follow-up. We'll talk about that and refer the source person to care because there's some nuances in that. So baseline testing, what are we looking at? We're going to look at the antibody and then if positive, confirming with the HCV RNA. This is a key point because it establishes whether the exposed person had a pre-existing infection before they were even exposed this time, because it hasn't been long enough for them to have antibodies from this occurrence. At your first follow-up, 3 to 6 weeks, this is the most important early test where interpretation is key. So an RNA negative, you would want to continue to follow that out later. But if RNA was positive, this is acute hepatitis C infection, and I would refer to care immediately. The clinical emphasis here is do not wait for that antibody. This is how you detect early infection. So final follow-up at months 4 to 6. That interpretation here, if it's a negative, no further testing. If it's positive, you have positive antibody. We will then want to look at an RNA and refer to care. That would see if they have active infection going on, but they also need to be further assessed. So after talking about hepatitis B and hepatitis C, let's move back to HIV. If the source person tests HIV negative, no follow-up for HIV testing is needed for an exposed person. An important nuance here is assuming that the source is not in that window period and there's no clinical concern for an acute HIV. That sort of changes the game a little bit there. If the person has HIV, repeating HIV testing at 6 weeks and then 3 months are the standard follow-up time points with the modern fourth generation testing. Routine testing beyond 3 months is generally not required with current antigen and antibody testing, but you could consider extending to 6 months in select scenarios. Remember, and an important 2025 update is that testing should be extended to 6 months if there's been recent exposure of our individual of concern with a long-acting PrEP. So think cabotegravir. This is because you can have delayed seroconversion of a potentially lower or suppressed viral replication. Moreover, there are recommendations for HIV follow-up at 12 months if the exposed person acquired hepatitis C at the same time. This can reflect a delayed HIV seroconversion in the setting of concurrent hepatitis C acquisition. So overall, think here 6 weeks, 3 months, and then there's a few special scenarios, specifically with long-terming injectables being one of our current mainstays of therapy. You need to think about these nuances. So exposure to HIV, hepatitis B, and hepatitis C requires immediate evaluation by a healthcare professional. So you want to report those exposures immediately and ensure close follow-up and adherence support. Key takeaways from me are typically acting immediately, reporting early, and then supporting our patients through this through the immediate as well as the follow-up period. And just to bring it back home, remember our goal is to remove judgment and normalize prevention and treatment discussions. So we want to create a safe space where our patients feel safe at disclosing risk. Patients don't fail care. Honestly, our care systems can fail our patients when that stigma is present. Focus on behavior, not that identity, avoiding language that implies blame or intent, and keeping our communication clinical as well as respectful and clear. Moreover, this process can feel overwhelming for both providers and patients. So really focus on these types of measures. The most effective post-exposure prophylaxis regimen won't work if our patients aren't trusting us enough to take it. So compassion is a clinical intervention that we have to highlight here. Here's some of my acknowledgements. I could not have done this without my training or without so many mentors that have helped me along the way. And I've provided some references as well. I know I answered a few questions throughout this, but I'm more than happy to take some more now.